to Eunice W. on a Saturday morning. Thanks for coming along. So I'm actually talking about enthesis, augmentation and rotator cuff repairs. Now, why do we want to think about augmenting the enthesis? Well, although rotator cuff repairs, patients are getting better and better and results are improving, we know that there are limitations to our rotator cuff repairs. If you're looking at the success rate, generally most papers, the success rate is between about 5 to 20%. In my experience, in relatively acute rotator cuff tears, the failure rate's more around the 5% rather than the 20%. I don't think anyone would be particularly happy with a 20% failure rate. But you do get patients whose tendons don't heal, no matter what you do. Also, when you start getting back into bigger tears, older tears, more attracted tears, which require more extensive surgical procedures, the failure rate can be as high as 50%. And although we do things to change that, for example, in large retracted rotator cuff tears, even if you're having to do interval slides, I always augment them these days with dermal allograft, and that decreases the failure rate by about half. But that still means you've got about a 25% failure rate, which is pretty high. And a lot of these patients are young, they need good shoulders to function, and a lot of them are manual workers. So, and the other thing we see, and you've all seen it, is someone's had a rotator cuff repair 10, 15 years ago, and all of a sudden it's gone for no real reason. They start getting pain in their shoulder, you get a scan and their cuffs fail. So there's something to do with the longevity of the repairs that we're doing at present. Now you can look at what factors are involved in rotator cuff failure rates. Probably the most important is the time to surgery. So if you've got a patient who's got a rotator cuff tear and they're not getting better with non-operative management and or they're young, that they need to be referred to the surgeon earlier rather than later, because delay does increase the risk of failure quite significantly. And why does that happen? It's multifactorial. Patients develop fatty atrophy. If the muscle's not loaded, it gets replaced with fibrous fatty tissue that doesn't recover. The tendon quality goes down. The tendon goes through metaplasia if it's not attached. It becomes more cartilaginous-like. And the growth factors within the tendon decrease, so it becomes less likely to heal over time. With time, you get fixed retraction, you get scarring, which involves complicated surgical procedures to get the tendon back, and often means you're repairing the tendon under some tension. Patient compliance is a big issue. Patients generally are not very compliant. No matter what you tell them, they think you've told them something else. And it's quite surprising when they come back what you find they've been doing. Smoking's a big thing. The reason smoking's a problem is nicotine's a powerful vasoconstrictor. So every time they have a cigarette, they're cutting off blood supply to the healing rotator cuff. Fixation, where the fixation's adequate. And also the technique you choose, and it has to be said, the skill of the surgeon. Rotator cuff repairs, especially arthroscopically, have a steep learning curve, so they do take a bit of time to get used to. So we can look at all these things, and when you look at where we've come from open repairs with big, deep, bony troughs, to use of anchors, to arthroscopic procedures, single row, double row. So we've done all these things, but yet we still have these failures. And what are we not addressing? We're putting grafts on the tendon to thicken the tendon thickness, which helps a bit, but it's obviously not the complete answer. And what's become an increasing focus in research for rotator cuff repairs is basically the enthesis, because with standard surgical repairs, we do not recreate the enthesis. It can look good, nice double row, you go, oh, that's fantastic, that's going to heal really well. But what happens underneath it is really the crux of the matter. So basically rotator cuff tears, and particularly repairs, they tend to fail at their enthesis. There tends to be a weak point. And what the enthesis is the interface between the very flexible tendon to the more rigid bone. So the tendon, or the repair tendon, gets avulsed from the bone, and the goal of the repair is to re-establish that connection and re-establish the force couples. So what is the enthesis? It's the interface between the tendon and bone, and it transmits force from the muscle tendon unit to the bone. And to do that, you get a sequentially increasing stiffness from the very flexible tendon to the very stiff bone. That allows safe transfer of the forces to the bone surface, and that allows the force to dissipate quickly from the enthesis, protecting it. And it's important to realise it's like articular cartilage, it's a highly specialised structure. And there's two main types. We'll talk about both just for completeness, but the first type's the fibrous type, and this happens to the metaphysis, diaphysis, the long bones. A classic example is attachment of the deltoid, and this is a very simple attachment. It's collagen fibres penetrate into periosteum, into bone, and why it is simple is because there's not a great change in the angle of pull on the attachment site. So if you imagine your deltoid, you look at the angle of pull your deltoid and raise your arm, the angle of pull doesn't really change at all. So it doesn't actually have to be strong. There's not a lot of shear forces through that interface. Going on to the next sort of enthesis, the fibrocartilaginous enthesis. This happens between the epiphysis and the apophysis. And why it needs a specialised structure here is there's a large change in the angle of pull. If you think of your supraspinatus, here you're pulling it perpendicular to the long axis of your humerus. Here you're pulling in line of it. So there's a lot of stress, a lot of shear forces go through that interface. So you need a more highly specialised structure to be able to cope with that. And there's 4 distinct zones, so you get a progressive transition from the highly flexible tendon to the rigid bone. The first zone is fibrous connective tissue. It's just essentially native tendon. It's full of fibroblasts, active cells, type 1 collagen, and different other types of collagen, a bit of elastin, proteoglycans, to give it its fluid content to its viscoelastic structure. The next layer is the layer of uncalcified fibrocartilage. So it's avascular rather than fibroblasts. It's got fibrocytes, which are less active. You get the proteoglycan aggregate, so it's still viscoelastic. You get increasing amounts of different types of collagen, and it's getting progressively stiffer through that zone. And this is the major area of force damping and decreasing the shear forces. The tide mark is the boundary between the non-calcified and the calcified areas. It's a basophilic line, which means it stains with basophilic stains. And the thing is, it's flat and it's straight, and that's to decrease stress and rises at the interface to protect it. Going on to the area of calcified cartilage, again, it's avascular, it's calcified, it's full of fibrochondrocytes, type 2 collagen, aggrecan, type 1 and 2 collagens, and this zone actually grows into the bone, interlocking into the bone, which gives a very, very strong mechanical fixation and very good force transfer. It's also a barrier for cell and blood vessel migration. So you don't want bone cells growing into tendon, or you do want tendon cells growing into bone particularly much. And there's also a barrier for infection, just an aside. And then you get bone with typical osteoclasts, osteoblasts, etc. Type 1 collagen and hydroxyapatite, which is the mineralised component of the bone, which is really important with respect to something I'm going to talk about later. So what sort of healing do we get in rotator cuff repair? We certainly don't get reconstruction of the enthesis. What we get basically is fibrovascular scar tissue, sort of amorphous mass, which is both mechanically inferior, both short-term and long-term, than the native enthesis. It forms in 3 stages. The first stage, an inflammatory stage, it lasts about a week. You get migration of platelets, production of fibrin, which is connected by fibronectin to a platelet fibrin mesh. They express various growth factors, which attract macrophages, which again release further growth factors. So the macrophages start secreting transformation growth factor beta, leading to fibroblast proliferation, formation of type 3 collagen, and that process takes about 5 to 14 days. Next goes to the remodelling phase, which is 14 days on to about 6 months, and where you get the scar tissue being remodelled by metalloproteases, also under the influence of many growth factors, most particularly transforming growth factor beta isotype 3. Now, when you look at that, you'll think, well, you know, the repairs are over in 2 weeks. Why are patients still in a sling? You know, why can't we start getting them lifting weights and going to the gym? Well, the remodelling phase is actually extremely important with gaining strength. And that's been demonstrated in studies which have put inhibitors into the healing interface, where they have inhibitors which inhibit transforming growth factor 3, which actually starts stripping down the scar tissue. And what you find with that, with unimposed TGF-1, you get a large amount of scar formation. And you think, well, that's fantastic, with lots of scar. It's going to be really strong, but it's actually weak. You need the remodelling to get the strength into that interface. So that's really important. So what do you get histologically? So in the rotator cuff repair, that's as you're looking at the scan on your right, you get this sort of amorphous mass of scar tissue compared to the highly specialised structure of the enthesis, which is is much inferior both in durability and strength. So how does the enthesis develop? Well, enthesis develops very slowly with the rest of us. So our enthesis developed during embryological development, and it's a complex interaction between biological and mechanical forces under influence of multiple growth factors. And hence, so therefore surgically, that's very difficult to replicate. When you're looking at attempts at enthesis reconstruction, a lot of this is extremely experimental. People are looking at multi-potential stem cells, various growth factors. And growth factors, you can synthesise a lot of these growth factors now, and a lot are commercially available. The thing with growth factors, because there's so many involved in the development of the enthesis, it's pretty naive to suspect that 1 or 2 added to the interface is going to lead to anything like recreation of the enthesis. It's also very expensive. And yeah, it's a work in progress. There's also scaffolds being developed. Normally scaffolds and rotator cuff repairs apply to the tendon, therefore they don't really have an effect on the prosthesis. A lot of them involve bioabsorbable plastics like PLA or bovine-derived collagen, which there's potential problems with. So going on to what things are being used clinically at the moment, we have PRP, platelet-enriched plasma. Platelet-enriched plasma in some ways could be looked as a treatment looking for a disease. It's used for lots of different things, somewhat randomly, somewhat people might say, but some things it shows that they might have a benefit, and that's certainly a work in progress. What you do though, it's easy to construct. You can do it in your rooms, and certainly you can do it in operating theatre very easily. You take some blood, spin down the platelet-enriched plasma, you either leave the leukocytes or you extract it, and there you go. And what it is, it's the platelets, but what you're really getting a lot of is platelet-derived growth factor B, and that has multiple functions. It's got chemostasis, cell proliferation, extracellular matrix proliferation, integrin expression, revascularization, collagen synthesis, just does it all. It's just amazing. It also has other growth factors in it. But looking at animal studies, it does show restoration of some features of the enthesis, but not all of them. And when you actually think about it, why would it? This is platelets are an acute phase reaction. They're not involved in the embryological development during enthesis. They're involved to produce fibrovascular scar tissue. And that's what they're going to do in this situation. What you probably end up with is a more robust, predictable production of fibrovascular scar rather than the reconstruction enthesis. So maybe that's not the answer, but it's still being investigated. Another issue is delivery. It's a fluid. In the arthroscopic environment, it's hard to make sure you keep it there. The most common way to use it nowadays is you basically put it, after you finish your repair, you put a needle in the interface, evacuate the joint of fluid and inject it in. So hopefully that leads to some staying there, but that is certainly a work in progress. This is what I think is probably the most interesting and exciting development in rotator cuff surgery for a long time, probably since the event of arthroscopy, to be quite honest. And that's the use of demineralised bone fibre for tendon healing. And a lot of the work's been done here at the University of UNSW with Dr. Bill Wild in the biomechanical engineering lab. And what the interesting thing about bone is that bone, as an embryo, your bone's developing, you get in, forms in cartilage, you get enchondral ossification. All the growth factors that are there for the development of the bone and the development of the cartilage and the maturation, they're still there. They're like a time capsule. What happens to them is as the bone mineralises, these growth factors get turned off, but they're still sitting there. If you demineralise the bone, they get reactivated. So sitting in the bone, sitting in the demineralised bone fibre, you have a plethora of growth factors. They code for bone development, they code for cartilage development, they code for tendon development. So everything you have there that you want to re-establish the prosthesis is there. You have a matrix which is conducive to cell proliferation and cell migration. So this stuff is very exciting. It has everything you need to reconstruct the enthesis. And that's what appears to happen in animal models. So it's osteoconductive, osteoinductive, stimulates tendon healing, and histologically and mechanically get recreation of the enthesis in animal models. There are some issues. Delivery. The fibres themselves are pretty friable. They can fragment in an aqueous environment. And up till recently, to demineralise the bone fibres, you had to put hydrochloric acid to it, and that led to destruction of the nanoarchitecture with demineralisation. Okay. So going on to, this is a new implant that's recently come out in the market. It's here in Australia in a very limited release. In fact, there's only 4 surgeons in Australia currently permitted to use it by the company. Duron's one, I'm another. And this is very exciting. You've changed the annealing process for the demineralised bone fibre to make it more stable in an aqueous environment. The demineralised technique maintains the nanoarchitecture to help with the cell migration and proliferation. And what the form it comes in at present is a form of a plug with a large flange on it. And you insert that into your punch holes for your medial row anchors, bury it onto the bone surface and put your anchor on top. So when you put your lateral row and your rotator cuff and it's held against this demineralised bone fibre at the tendon bone interface. It has an additional advantage is it does increase the pull-out strength of the anchor quite dramatically. And looking at animal studies, this again was done here. The top two are looking at tendon. So basically, the control on the left. What they've done is just split the tendon longitudinally. This is infraspinatus in sheep using the contralateral limbs as control. So they've just split the tendon on the left. On the right, they've split the tendon and put a demineralised bone matrix patch on it. And what they've found is that the demineralised bone matrix patch results in increased thickness of the tendon. And the images below, the one on the left, we've detached the infraspinatus, done a double row repair, and the one on the right, we've done that, but put the bone demineralized bone fibre at the interface. And you can see the difference on the MRI scan where this interface looks actually quite mature. There's thickening of the tendon, where the control still looks very immature. Okay, and just looking at that histologically, the one at the top, again, an vascularized fibrocartilage, and on the bottom, recreation of the enthesis, and this is polarized light microscopy showing a reproduction of normal-looking Sharpley fibres. So we're very excited about this. We think it's going to be a very exciting thing, and hopefully it'll minimise the risk of a failure rotator cuff repair and also allow more aggressive early rehabilitation. Thank you very much.